Hello everyone, your brain is a muscle. If you don't use it, you'll lose it. So, don't stop practicing. Let's go to the gym. I'm Dr. Ahmed Abdul Wahab and I'll be your coach for today. Stay with me. Hi dear.
Hi, sir.
How are you?
I'm fine, thank you.
Would you like to start training session today?
Yeah, sure. That's what I come here for.
Excellent, good job. So, let's start. I have an MRI case here of a 10-year-old male patient presented with a pain in his left leg with fever and there is some sort of skin laceration or sinus or some sort of skin discharging focus. So X-ray was abnormal and then MRI was recommended for him. So would you like to start?
Let's start with sagittal T2 weighted images. I want to scroll first through these images to have an idea of what is going on. Okay, can we have coronal images?
Yeah, sure. These are the coronal T2 weighted fat saturated images.
Can we see a non-fat saturated images?
We have this T2 non-fat fat saturated images.
Oh, these are beautiful. Okay, I think I can start commenting on the case. So these are the T2 and T2 fat saturated images of the left leg of a 10-year-old male patient, showing that there is diffuse bone marrow edema seen involving almost the entire visualized part of the tibia. It's all edematous, showing us increased T2 signal intensity, of course, with edema of the adjacent surrounding soft tissues.
Good.
And on the T2 weighted non-fat saturated images, we can see that there is some sort of abnormal signal intensity, linear or serpiginous, tracking within the medullary cavity of the tibia, and I can see there's probably some sort of cortical erosion route around here with a fluid collection that we can see here, although it's suppressed on fat-saturated image. And I can see that there is probably a cortical erosion right around here. And axial images will be helpful in that regard.
Okay, let's see the axial images.
So these are the axial T2-lated fat-saturated images of the leg, showing the previously described diffuse bone marrow edema and some sort of serpiginous cavity within the medullary cavity of the case with marked edema of the surrounding soft tissue, and there is a cortical breach here with some sort of hypointense signal right around here. Probably some sort of fat-containing collection. And I think there could be some skin abrasion or extension to the skin. What I'm not so sure.
So, what do you want to do?
Let's see T1 weighted images. So these are the T1 weighted images, axial images, and we can see that this lesion, it's again bright on T1 and it was suppressed on fat-saturated images, suggesting it's some sort of fat-containing lesion, and clearly we can see there is a big cortical erosion right around here in the anterior surface of the tibia, and through this erosion, the edema or the inflammation or the pathology is like leaking from the middle ear cavity into the surrounding soft tissues here and there.
So what's your differential diagnosis or diagnosis here?
Well, I think it's some sort of osteomyelitis of the tibia. However, I would really like to see some post-contrast images to see the pattern of enhancement.
Okay, I'll give you some post-contrast images.
So these are the axial T1 weighted post-contrast images. If we compare it with a pre-contrast images, we can see that there is a diffuse post-contrast enhancement of the medullary cavity, and we can see the cortical erosion here, and we can see that the areas or the soft tissue surrounding the tibia is clearly diffusely enhancing. If we correlate that with the sagittal T1 post-contrast images, we can see that there is an area of cortical erosion here, and we can see the diffuse post-contrast enhancement, and probably this is some sort of skin extension and opening into the skin just right around here like that. So this confirms my suspicion of an osteomyelitis with abscess formation involving the distal, probably half of the left tibia, caused with a cortical destruction and extension into the soft tissues surrounding the tibia with a sinus tract into the skin, resulting in chronic discharge from the skin. So this is my diagnosis. I don't know whether I'm right or wrong.
Well, you're definitely right. You are a very good diagnostician. Your description is remarkable. It's logical and step by step, and you take your time in the process of diagnosis. Keep going. You are getting better and better. The training is obviously working.
Thank you, sir. That's good to hear. Okay, thank you. Bye-bye.
Bye-bye. So this was our exercise for today. If you want any private training session, send a message to the email in the description box. We will arrange something. See you next time. Bye.